Dr. Coleman is the chief of the Department of Urology at the Howard University School of Medicine. She's also the president of the medical dental faculty at Howard University, and she is the director of community outreach on prostate cancer at Howard University as well. And so we are really blessed to have such a, a stellar group of individuals who are with us today. I, I mentioned my mentioned Dr. Pamela Hamilton Stubbs, the founder, principal founder of Dr. Hamilton Stubbs Sleep and Total Wellness Institute. And just by way of her background, I should mention that she is a peer-reviewed author of a half a dozen articles and book chapters, principally on restless leg syndrome. She's a co-author of those chapters, and as well as a clinician, and founded an independent medical practice in Richmond, primarily focused on sleep disorders. However, when I was diagnosed with prostate cancer, she revamped the medical practice and expanded it to include wellness so that she could help save my life, for which I'm very grateful. So I do want to acknowledge her as a principal driving force in this in tonight's program. In a moment, we're going to begin with our first presenter, and that's Dr. Coleman. Um, at this time, I'm going to call on Dr. John Henry Scott III, pastor of Jesus Stands for Love and Justice Ministries in New Haven, Connecticut, to give us an invocation.
Thank you so much for this honor and privilege. Let us pray. Father, Sustainer, Redeemer, we thank you for Dr. Pamela Hamilton Stubbs and the Reverend Dr. Attorney Professor Jonathan K. Stubbs, and for this fantastic ministry. We pray for all who are with us right now. We thank you that you give us scientific knowledge for healing. We pray for all who are participating in this program. May this knowledge be used to build a bridge on our health, that we can all become healthier, more productive citizens to make this world the abundant life world it should be. In Jesus' name we pray. Amen.
Amen. Amen. Thank you so much, Pastor Scott. Appreciate your enduring support and your kindness and your love over the years.
Thank you.
We're now going to turn to Dr. Pamela Coleman, chair of the Department of Urology and Surgery at the Howard University School of Medicine. And Dr. Coleman will take it from here. Thank you, Dr. Coleman, for being here. I know as a clinician, your schedule is unreal, but you've made time for us, so we appreciate that. Would you unmute yourself, please, Dr. Coleman?
Yes, thank you very much. And I really do appreciate being invited here and to be here today. I started my morning actually talking to transplant patients on having a healthy urological system in our golden age. So I will end tonight talking about prostate cancer. So that's great. I do have a few slides that I'd like to share. So I'm going to.
Yes, you're able to share your screen.
Okay, great.
Mm-hmm.
Okay. I actually don't see my slides. Let's see, the screen.
We could see them.
Oh, you can see them?
Yes.
Okay, great. Okay.
Yeah, we can see them now. Yeah.
Okay, great. So let me go back. Let's see, we're starting back at the report. Okay, great. All right, so good evening again. We'll start. So I was charged with talking with prostate cancer, understanding prostate cancer from diagnosis to prevention. So I thought I would give first a slide. Many of you may know this already on what is the prostate and where is it located. So in this slide, I wanted to point out, let's say, sort of an opening inside of our body, our spine, our pelvic bones. And here we have the bladder, and right outside the bladder is the prostate gland. It surrounds the urine tube or the urethra that runs inside the penis that men urinate through. And as we know, the prostate gland is only found in men. I will say that in transgender females, we do not, at this point, remove the prostate gland. So the prostate is there, and that poses for them, as we'll talk about later, a risk for prostate cancer. What do we think the function of the prostate gland is? It seems as though its primary function is to produce the fluid that nourishes the sperm that are made here in the testes, make their way up the vas deferens, and that nourishment then allows those sperm to be able to swim uninhibitedly through the seminal fluid and out with ejaculation. Now, this prostate gland, though, is made up of cells that are benign, but for some reason, and not unknown, as it's not unknown for most cancers, they can become malignant. So prostate cancer then, as most cancers are, it's an abnormal, uncontrolled growth of cells that occurs in the prostate. For whatever reason, these cells are there and they're turned on and they grow at their own mind, their own wishes, their own heartbeat. But keep in mind that this growth can be slow growing. So not all prostate cancer cells are fast growing or malignant in nature. It's very, very common to find these prostate cancer cells in men over 50, but as I will talk about, there are some higher risk factors, particularly in African-American men. What are these risk factors? Well, just one, being a male is a risk factor and having a prostate, but certainly the risk increases after age 50. And in terms of ethnicity, there is certainly quite a higher risk in African-American men compared to other men. There is also increased risk with family history. If there's a father or brother or son with prostate cancer, we might want to be more in tune for screening that person for prostate cancer. And also there are those that have a history of breast cancer in the family. They're looking at biomarkers and genetic blood tests, blood or urine or tissue samples. Those that have an inherited mutation, either a BRCA1 or BRCA2 or HOXB13 gene, can be more at risk for having prostate cancer. And unfortunately, having these genes exposed also tends to have more aggressive type of prostate cancer. The other risk factors is looking at our diet, and I think we're going to be talking about that later on too with one of the other speakers. But a high-fat diet, a diet that's high in red meat, a diet that's high in preservatives, can increase the risk of any cancer, colon cancer, and also prostate cancer. Common symptoms. In general, for prostate cancer, particularly the early stages, there are no symptoms. So this is why it's really important that we do have the blood test, the prostate-specific antigen, to screen men for prostate cancer. Just how lovely would it be if we had such a test for women in breast cancer and other cancers, but we do have the PSA blood test. But there are some symptoms more commonly seen with BPH or benign enlargement of the prostate gland, which can include a weak or interrupted urine stream. And as we get older, both men and women, the bladder becomes less compliant, meaning that it may hold less fluid and there may be a weak stream, trouble starting or stopping the urine stream, getting up at night, Frequent urination. So in general, adults drinking adequate amount of fluid should urinate about 6 to 8 times at night, 6 to 8 times during the day, I'm sorry, and not get up more than twice at night. So getting up at night may be a symptom. It's more common with BPH, but it's certainly that's something that needs to be investigated if it seems to be persistent. Blood in the urine or blood in the semen, medically called hematospermia, may also be a sign that something needs to be looked at or evaluated. Pain in the hips, back, or chest if it's advanced. Prostate cancer is known to commonly spread to the lymph node tissues, the pelvic node tissues right outside where the prostate is located, as I showed you on that first slide in the pelvis. But it can also spread to the bones, it can spread to the chest, and then as it grows, it can spread throughout the body. So why does screening matter, particularly for African American men? Well, there is a higher risk of developing prostate cancer. As I've told you, the risk factors, particularly in African American men, they're 70% more likely to be diagnosed with prostate cancer. And unfortunately, at one point in time, they were more likely to be diagnosed with aggressive cancer. Now, this aggressiveness is not necessarily due to any particular difference in the cells themselves that cause prostate cancer, but probably related to other factors such as early screening. Maybe even there are what are called epigenetic factors that influence the cells over a period of time, from some believe actually from slavery to presently conditions where African American men may be growing up in neighborhoods that don't have adequate food to eat, or under the pressures or stress of daily living and things like that. The disease does tend to occur earlier in African American men, sometimes even before the age of 50. So in African American men, it's recognized and pretty much common habit now to start screening at the age of 40 and over. And even at that age of 40 and over, the normal PSA or prostate specific antigen test is usually in the range of less than 4. But when you're screening for men that are younger, you're probably looking at a PSA that should be less than 2.4. Genetic factors, as I've mentioned, family history and biological differences in tumor behavior all play a role. So in African American men, early detection does save lives. Is it a more aggressive disease? Well, that's being studied. Like I said, genetic factors and also epigenetic factors. But these tumors tend to grow and spread faster. The later diagnoses can lead to a more advanced stage, and I'll speak about stage and grade. And again, early detective allows for more effective treatment. We can get the cancer earlier, the treatment can be better, and in some cases, the treatment can even be curative. In African American men, going back to why screen, because there is a higher mortality rate. African American men are twice as likely to die from prostate cancer. So early detection significantly improves their overall survival rates. Now, how do we screen? In these days and times, it was pretty much taught screening was with the PSA, or the prostate specific antigen, and the digital rectal examination. These still both can be done, but general screening now with the PSA is very common and routinely done. So I will tell my patients, and also when I'm speaking to primary care physicians, in men that are over 40 and African American men, or men that have a high risk of prostate cancer in their family, consider when you're drawing that cholesterol level or the sugar level, or hemoglobin A1C, put in for a PSA. The PSA, prostate specific antigen, may be normal, but it gives you a baseline from whence to start. It gives you a point to maybe have a shared decision-making with your patient, with your doctor, and also a point to see if there's an increase in the PSA or increase in the velocity from year to year that also may signal that something is going on in the prostate besides benign growth, possible prostate cancer growth. I can't overall emphasize how important screening can be in early stage detection. because patients that have early stage prostate cancer have nearly 100% 5-year survival rate. So what cancers can you think about that if you can detect it early, you have 100% 5-year survival rate? Screening also helps identify aggressive versus slow-growing disease. Some may say, well, what about overscreening? Are we diagnosing by prostate biopsies too many men? Well, this was looked at early by the United States Services Preventative Task Force, and it was thought that when PSA came out that perhaps we were overdiagnosing men with prostate cancer, and they actually had a less aggressive cancer. Well, the cohort that was looked at in that were primarily men in European countries and Caucasian men, and not men in the African American group, where we do see this more aggressive prostate cancer. So the information has been modified, as I mentioned, to start screening earlier in those with a higher risk factor. So for African American men, early detection means protection. Diagnostic tests that can be used are listed here. The PSA, as I mentioned, it measures the prostate-specific antigen. The digital rectal examination still, I believe, is important. I still perform that in men that will allow me to do a digital rectal examination. Not everyone wants one, and now I understand their wishes, but I would like to get their PSA. But they're not all prostate cancers produce prostate-specific antigen. Sometimes they're only palpable as a nodule or firmness or hardness on the rectal examination. MRI or ultrasound imaging now are very helpful tools that can help give us a 3D ID look at the prostate to look for abnormal areas, and certainly to confirm that a biopsy needs to be done. I will say that changes in biopsies nowadays from a transrectal biopsy, which meant putting a small needle through the rectal wall and possibly inducing bacteria into the prostate and leading to infection, now can somewhat be changed by doing a transperineal prostate biopsy. So putting the needle in between the skin from the anus and the base of the scrotum to obtain a sample. And so less like chances of developing infection in urosepsis or urinary tract infection afterwards. Understanding, though, that the PSA is the enzyme, like I said, that cleaves the cells, that allows the sperm to swim freely to their destination, is not totally specific for prostate cancer, but it can be seen increased with infection and also BPH, or benign enlargement. So BPH is a non-cancerous growth. It can have very similar symptoms that I mentioned earlier, and it's probably actually more common than even prostate cancer itself and occurs in most men. So doctors have to interpret the PSA with the age of the patient, because it can be a bit higher if you do age-adjusted PSAs, and also the ethnicity and the overall history. Staging and grading. Well, the stage gives us an idea of how far the cancer has spread. Has it spread outside of the prostate capsule? Has it spread into those lymph node tissues or the bony tissues that I suggested? The grade, the score that came after Dr. Glycation in the 40s, who looked at grading prostate cancer, this gives us an idea of how aggressive the cells appear. So in general, the grading, we look at Gleason grades. The pathologist looks under the microscope at the biopsy specimen and gives an idea on each side of the high power field what those cells look like to give a score. So in general, Gleason scores that are grades of 3+3 or 6 or less are usually considered not to be as aggressive tumors as if there's a Gleason grade of an 8, 9, or 10 or more aggressive. And then in the middle, we have Gleason score of 7. One can get a Gleason score of a 7 with a 3+4 or 4+3 cells under the high power field. And a 4+3 is considered potentially more aggressive than a 3+4, meaning that there were more higher cells seen under the gland. They were not particularly forming glands. And this is very important because our treatment sometimes is very much guided in the choices based on the stage and the grade. Genetic testing is very important because it gives the family the patient and the rest of the family an idea of the risk. The cancers that are emitted that can be leaked to these inherited genes. These genetic mutations have been shown to have increased the risk of prostate cancer and more aggressive prostate cancers. They are also used nowadays to help with the treatment of prostate cancers. There are treatments that can be used for those where we see a genetic mutations with the BRCA1 gene that are not used for other cancers. It also helps to identify the family risk and guide treatment. I believe this counseling, this type of genetic counseling, makes prostate cancer not a one-size-fits-all, but it gives us another tool to try to address the specific treatments tailored to that particular patient. And I recommend it, and it's very commonly now used in the scope of practice for those with the family history looking for early versus aggressive cases. And these type of genetic testing can very commonly now be done with the blood. I mean, the PSA is actually a type of beginning of genetic testing, saliva testing, and also tissue testing after a biopsy is done. The treatment options can include with the slow-growing cancers after surveillance. After surveillance means monitoring the patient clinically in the PSA every 3 to 4 months versus a term that used to be called watchful waiting. Watchful waiting is that we watch and we wait until the symptoms occur, bone pain, weight loss, things like that, and then we treat. So kind of behind the eighth ball there. But this may be suggested for some patients who maybe not candidates for treatment. Surgery, removal of the prostate gland is thought, well, if we take the prostate gland out, then I don't have to worry about it. But you have to about prostate cancer. But one must keep in mind that sometimes there are microscopic cells outside of the prostate that are not seen. And 1/3 of patients that do undergo prostatectomy may have a recurrence. But again, now we can use that PSA to monitor these patients and determine if they need salvage therapy. Radiation therapy, there are different types. This is targeted at the prostate itself to kill the cancer cells. And hormone therapy, we know that the prostate, both benign and malignant cells, are sensitive to the male hormone testosterone, which is produced by the testes, the adrenal gland, which sits over the kidneys, and also the prostate cancer cells themselves. So we can manipulate the hormone, the testosterone in patients to treat prostate cancer. And then for more advanced cancers, we're looking at chemotherapy and even immunotherapy. Immunotherapy actually has been found to be actually quite good in African-American men, again, if we catch the cancer early. So screening and overdiagnosis I've kind of touched on already, but screening can detect early cancers and may find some harmless cancers, and so therefore possibly leading to overdiagnosis. So this is where it's important to have a very well shared decision-making with the patient, their family, and the urologist, the doctor, and really discuss the screening age and that frequency. If someone has a PSA at 50 and it's only 1 + 0, and I remember I said 4 is higher, they might not necessarily need a screening test every year. They can possibly be followed. So prevention, well, there are maybe a few cancers that can be prevented. I can think of cancers that deal with cervical cancer and HPV. Right now, there are studies being looked at preventing prostate cancer, but we certainly know that healthy living is important. Eating a low-fat, plant-based diet rich in fruits and vegetables, limiting the red meat and processed meats, staying active and maintaining a healthy weight. There are drugs that are being studied, but presently there are no proven drugs that prevent prostate cancer. And in general, we all should avoid smoking and limited alcohol intake. Living with prostate cancer, men are living longer, fulfilling lives after the diagnosis. And so it's not a death sentence. We certainly have a lot of different treatment options. And we have a way to follow with the PSA, how the prostate cancer, if it's present or if it has returned. So regular follow-up visits are vital. We need to manage the side effects of some of the treatment options that we do have available for prostate cancer. And it's so important to have emotional support and family involvement, I believe, are key in the management with any cancer. Screening is an act of self-care and community care. And so when I speak to community groups about prostate cancer, I tell them empowerment through awareness is key. You need to know your PSA as you would know your other health numbers, like your cholesterol number, your sugar number, your hemoglobin A1C. And I believe it opens conversations to reduce fear and stigma. We've often looked at doing prostate cancer screenings or talking about prostate cancer in the barbershop, where men are there and getting things taken care of with, and try to reduce the stigma. A lot of times I will hear people talk about the Tuskegee experiment, and that was wrong. That was bad. That never should have been done. But nowadays we have people of Black and brown skin who are also taking care of patients, and we have different FDA rules and regulations in place. So something like that should not ever happen again. But we have to have this open, continuous dialogue, starting at an early age, to help reduce the fear and the stigma associated with any cancer, prostate cancer. So my key takeaways that I'd like for you to remember tonight is that prostate cancer is common, but it's often treatable when found early. The risk factors that we talked about, age, I will say not just the human race, but ethnicity, family history, and diet. And genetic testing really helps personalize care. Nothing but trying to have a very healthy lifestyle also supports better outcomes. Some of the resources that you can look for, the American Cancer Society, the National Cancer Institute. Here at Howard University College of Medicine, we do offer free PSA screenings and genetic testing, and all these can help support better outcomes. So with that, I will end and say thank you very much for your attention. And I'm not sure if we're taking questions at the end or questions now.
Thank you very much, Dr. Coleman, for this comprehensive and clear and extraordinarily helpful presentation this evening.
Thank you.
We are just going to have one question
Okay.
at this time, and I got a question with regard to the CDC guidelines, which apparently suggest that the PSA test ought not to be a regular part of the screening as often as it once was. I'm not quite sure of the details of this guidance, but I'm sure that it's probably something that has come up with folks who are afraid to take the PSA test or have been recommended not to take the test. What are your thoughts on the PSA test and whether or not, notwithstanding whatever the CDC is saying about discouraging that, it should be done?
Thank you for that question. And I will tell you that my thoughts, as I've talked about in this my PowerPoint, that the PSA test is so very important in men that are at high risk. The recommendations initially from the U.S. Preventive Service Task Force, like I said, was in a select population of patients that are not necessarily the patients that I serve in my community. So I have to take that into account. The recommendation was given as a stage recommendation of a D stage, but what is known also with the AUA guidelines in the National Cancer Institute, and I believe also in the CDC, is there should be shared decision making. There should be a discussion with the patient and the family to discuss prostate cancer screening or getting the PSA done, because that's what we're doing in the screening. Certainly if someone has symptoms, we're no longer screening at that point, and we're actually looking for a diagnosis of how we can help that patient. So it's really important to have this communication, this informed consent with the patient and with the family as needed. If you have a patient that is nursing home bound and has other morbidities, one may not want to do a PSA screening in that test because it may add more morbidity. Sometimes we look at the 10-year survival rate. We look at how healthy. So not necessarily the chronologic age of the patient, but the physiologic age of the patient. The screening is looked at between ages 40 and 74, but people are living longer. I have healthy 80-year-old patients that sometimes they do want to be screened because of their family history and risk factors. And if they do, when they want to be screened, whether or not, if something is found, do they want to continue on the other steps, going through imaging tests, biopsy and treatment. So I would say that it's important to have that conversation with the patient and the family and then make a decision.
Thank you very much, Dr. Coleman. That's a very helpful response to a question that I'm sure a number of people have concerns about. We're going to have time perhaps for more questions at the end of the program, but now, to be fair to our other presenters, we're going to turn to Dr. Dave Turner, who is the Vice Chair of Research at the Virginia Commonwealth University Massey Cancer Center. Dr. Turner is going to talk with us about advanced glycation end products, among other things, and I'll leave it to him to guide us through this part of the presentation. Dr. Turner, thank you. Dr. Turner, would you unmute yourself, please?
Yeah, I said at the start we should count how many times I forget to do that. So there's one. So again, thank you for allowing me to talk today. And my research is a little bit different. It sort of looks at how lifestyle really impacts cancer, and specifically how social determinants, environmental factors actually interact with the biology and the tumor biology, and how that affects how the tumors grow and how they progress. Because I think when we look at a tumor, it's not just the fact of looking at the biology, it's looking at the lifestyle, and it's looking at the sort of whole picture. And one of the things I use to do this is these are things called the AGEs, or advanced glycation end products, and I'll explain what they are. But first of all, I just want to say that the way we live our lives influences our chances of getting cancer. And living in a healthier lifestyle can help to avoid a cancer diagnosis. It can help treat cancer once it's diagnosed, and it can really improve quality of life when living with cancer. And because of the successes in cancer treatment, there's a lot more cancer survivors that are obviously living with cancer. So this becomes a big issue. And having said that, one of the real sort of issues is that convincing people to make lifestyle changes is really quite difficult if they don't understand why we are making them. Outside in the media, there's a lot of contradictory information about lifestyle, especially when it comes to diet. Coffee's good for you one day, it's bad for you another day. Red wine is the same. And although the specific guidelines of eating healthier fruits and not eating the red meat still stand, there's still a lot of apathy out there about how lifestyle actually affects the tumor and the tumor biology. And I've sort of used these things called advanced glycation end products to sort of make a story about these things. So advanced glycation end products, they're sort of metabolites that form within the body. This can't be stopped. It's happening all the time. One of the major sources of this is when sugar comes into contact with proteins, fats, and DNA within the body. There's a structural rearrangement between these two factors, and this leads to the formation of an advanced glycation end product. Hardly anybody's ever heard of these things, but we're exposed to them every day in the lives that we lead. And to sort of give an idea of what that is, like I've already said, how these sugars and protein fats come together, that forms an age. So the only way we can get rid of these ages that form in the body is when we visit the restroom. But unfortunately, this is really quite inefficient, and these ages actually accumulate in our bodies. And this starts from the day we're born and it continues till the day we die. And what this does is actually it causes tissue and organ decline over time. So these advanced glycation end products are part of the normal aging process of the tissues. And one of the sort of big examples of that is wrinkles in the skin. Ages contribute to that because they bind to collagen, which is one of the sort of structural proteins within the skin. Over the years, this builds up and it leads to the formation of these wrinkles. And if you can imagine the same thing happening to every organ in your body, this is a sort of tissue decline that ages can cause. Now, the ages are becoming an issue because the modern lifestyle is meaning that we're being exposed to many more of these ages than we were before. Dietary habits, high sugar, fat processed foods, frying, grilling, broiling, all increase ages. Smoking, drinking, even low physical activity can really affect how many ages we're exposed to in the body. And of course, a lot of these dietary habits and whether you smoke and drinking are related to neighborhood and built environment. For example, if you're living in a food desert, you can't really get the healthier foods, which are actually low in ages, and more, and you're going to eat more of these high sugar, fat processed foods, which are high in ages. Even UV exposure from the sun can increase how quickly these ages form in our bodies. So now, because of all this modern lifestyle and we're exposing ourselves to more of these ages, they're accumulating in our tissues and organs a lot faster. And this means that we're getting faster tissue and organ decline over time. And this has been called biological aging. So you might be 20-year old, but you've been exposed to so many of these ages that your organ tissue decline, your biological aging, is really going to be a little bit higher. You could be around 40. And that goes back to what Dr. Coleman was saying when she was talking about physiological age of the patient could be very different from the chronological age. And one thing that happens that we've been looking at in my lab is sort of how does this really work and combine and contribute to cancer? Now, just to sort of get this, I mentioned that ages accumulate in the body from the day we're born till the day we die, and that happens with our chronological age. We can't stop that. It's part of the normal process of growing older, and it's a result of mainly metabolism in the body. But like I said, now because of the modern lifestyle, we're really getting faster age accumulation, and now we're getting biological aging. And if you think about it, we're seeing cancer patients we're seeing cancer in 20-year-olds. It's just it, and that's a disease of old age. So we're seeing that people that are younger are getting diseases that are associated with older people. And one of the reasons that's thought to be behind that is this biological aging. And we think these ages contribute to that. Now, one of the big areas I talked about was where ages are in all the foods we eat. They're naturally there, nothing we can do about it. And I talked about how the neighborhood and built environment, social economic status, even the policies and laws that do food subsidies and farm practices, they can really result in higher ages, mainly through high fat, high sugar processed foods, frying, grilling, and even the broiling of foods can make these ages form in the body, or they can really expose us to more of these ages when we consume these foods. So basically, you can get direct exposure. So this is ages that are already in the foods we eat, and I'll talk about a few of them in a minute. And when we consume them, we're throwing ages into our body. But we also have an indirect formation, and that happens when we overeat. So the proteins, carbs, and fats, excessive consumption of these can lead to this age formation. You can lead with the proteins coming into contact with sugars, fat, and proteins, and it leads to this age formation. So we have a direct exposure when we eat these things, but we also have endogenous formation or formation in the body when we overeat with protein, carbs, and fat. So I said I'll give you a few examples. So all foods naturally contain ages. Carrots themselves, 3 ounces of carrots has a value of, say, 12 age units in 3 ounces. If you looked at fish, it has around 450 of these ages in 3 ounces. Chicken has around 800 ages in 3 ounces. So you can see these foods naturally contain this. So when we consume this, we're given a direct exposure to ages. The other way that ages can be formed is through heat. So heat drives that reaction. I talk about them sugars reacting with the proteins. When you apply heat, that reaction happens quicker. So ages form quicker in the food. To give you an example, 3 ounces of a steak has around 800 age units. You use a moist heat, a slow cooker, that goes straight to 2,600 age units just by the way we cook it. But if you use a high dry heat, that really forms a reaction and you get around 10,000 age units. Now, if you do the same thing to a carrot, which has around 2, when you boil it, it goes to 5. And when you actually roast it, it goes to 20. And this is because there's not many of the sort of reactants that's needed to form ages. So even when you apply the heat, you don't get a lot of ages in it. One thing I haven't mentioned up to now is ages taste fantastic. That charred areas or the caramelized areas is jam-packed full of ages. In fact, ages were discovered because somebody in the 18th century wanted to know why toast went brown. And that brown on the toast is ages forming in the bread right before your eyes. So one of the big things I get sort of, I'm not very popular for is bacon. Everybody loves bacon. It tastes fantastic. And one of the reasons it tastes fantastic is that it has around 90,000 ages in 3 ounces. Now, this doesn't mean a lot at the moment, but the studies coming out of New York are starting to show that we should be exposing ourselves to about 20,000 age units a day. So these 3 slices of bacon has nearly 4 times what we think we should be exposed to. So it gives you an example that we're really exposing our bodies to a lot more of these ages than we did a few years ago. Food processing is one of the big areas that we're really sort of increasing our age exposure. Things like extrusion, retorting, and irradiation are some of the 3 most popular sort of processes used to manufacture our foods. And they really sort of, they have examples as well. The macaroni cheese our kids love has 4,000, processed cheese 8,000. So again, you're really consuming these things and we're exposing ourselves to the ages. Now, why should we care on this? So ages have been found to be higher in virtually all chronic diseases. Now, this includes heart disease, diabetes, and Alzheimer's. And it's also been shown in our lab, we started, they're very high in cancer patients. But it's not just them, it's very much that they're doing. And part of this is because inflammation is one of the drivers of all chronic diseases, including cancer. And what these advanced glycation end products can do is cause chronic inflammation in the body. So if we're exposing ourselves to too many of these things, we're causing an inflammatory environment in the body. And I think pretty much everyone's aware now that that inflammation really drives a lot of these diseases. And it can either cause the cancer, it can make the cancer worse, or it can make the cancer progress a lot quicker. So we can see how these ages can do things. So a lot of our research, so we've done a lot of different things. We've done basic science, population science, drug discovery. We're really trying to take a holistic approach to this to show that it's sort of lifestyle and biology that we need to be looking at when we're making a cancer diagnosis. We've shown in prostate cancer that ages promote a tumor environment that's conducive for aggressive tumor growth. We've shown that age levels are higher in Black men with prostate cancer than white men. And we've also shown, one of the more frightening was that during puberty, ages can disrupt mammary gland development, and they also can increase breast cancer risk in later life. And we know that there's certain things happen during puberty in girls that can really increase the risk of breast cancer 40 years later in later life. So these ages may have some sort of role in that as well. We've shown that age consumption increases cancer risk, aggression, and mortality. And we've shown that high age levels in the circulation or in the blood is associated with aggressive markers of cancer. On the drug discovery side, we've shown that age levels in the blood can be reduced in prostate cancer patients with drugs. And we've also developed a lot of models to look at these advanced glycation end products, specifically with a focus on lifestyle, ancestry, and how that affects tumor biology. We've also shown that ages may promote resistance to chemotherapy. So we're sort of saying that if you do have a prostate cancer diagnosis and you're exposing yourself to a lot of these ages through the diet, it might actually be affecting the efficacy of that treatment. Now, these experiments are early on, and we're not saying that's the case yet, but there's definitely a possibility that that could be the case. On the brighter side, we've also shown that physical activity in clinical trials reduces age-induced tumor growth. And I think that's because it really burns off a lot of the things that's needed to make an age. So if you're exercising, they're not lying in the body, so the age doesn't form. One sort of really exciting data, we've got time restricted eating is where you only eat a certain time of the day. My wife does this between the hours of 10 a.m. and 6 p.m. That's the only time she eats. In our experimental models, if you time restricted eating, you reduce the age-induced tumor growth by 50%. Now they were eating pretty much the same amount of ages, but just eating within that window really reduced their sort of harmful effects. And of course, that we do a lot of outreach, which is why we're talking to you today. So what can we do about ages? So we're really sort of dedicated to making people age aware. They're very different. Nobody has heard of ages. And we're really using community partnerships like we're doing today to really spread the word. Where ages are very different is that they're produced by fat, sugar, protein consumption, processed food consumption, lack of exercise, even UV exposure. So they're a big sort of ubiquitous marker that reflects lifestyle rather than just looking at a fat, looking at a protein, looking at a certain sort of diet pattern or something like that way. Ages reflect lifestyle and how they accumulate in the body affects that lifestyle. So age reduction in foods, we're really pushing to change the way food manufacturers, especially processed food manufacturers, make their foods. There's things they can do that could reduce the age level, so we're not exposed to as much of them. And like I said, physical activity, studies indicate that regular physical activity can help reduce age accumulation in the body. We also reduce risk behaviors like smoking, drinking alcohol, which are basically things we're already doing, but these advanced glycation end products sort of give us a different picture to that. So just some quick tips here on change how we cook foods to reduce age levels. So know your food age levels. I can give out, we have an anti-age foundation. It's a non-profit where we're just trying to provide information. And we have a table of 500 different foods, cooked and uncooked, and the age levels within them foods. So we know that, so we know what actually we are eating and how many we're being exposed to. So if you're eating a lot of high age meals, you could choose to have a few low age meals a few days after, so you can really sort of control how many ages you're exposed to. You shouldn't overcook meats. Like I said, that burned charring area that tastes so good is jam-packed full of these advanced glycation end products. So overcooking is not the greatest. Then when preparing dishes that call for browning, such as stews and roasts, we can skip the browning step and just cook them straight away. And again, that substantially reduces the age levels. One great tip is acidic marinades like lemon juice, vinegar, and tomato juice. If you marinate a chicken and then fry it, it normally has around 10,000 age units in it. If you use one of these sort of acidic marinades overnight beforehand, it can reduce that by 50%. Because again, that acidity stops the ages from forming within the food when you cook it. So we have, like I said, we have a lot of information, and I can pass this on to Dr. Stubbs and things to sort of look at. There's a lab age video that I was going to show you, but we probably don't have time for that at the moment. And so I can send a link to that as well. And like I said, one final thought. I've talked about how these things accumulate in our body. So these are my 11-year-old twins now. They're for an old picture. But if you imagine how much we could reduce age exposure and their accumulation in the body, if when our kids are young or when we were young, we really cut down the high age meals by 50%. And if you imagine over a lifetime, this may have a significant effect on overall health as they grow older, as our children grow older. And again, this might reduce the biological aging of their organs and being an older disease again. So that's sort of where we are at the moment with this stuff. I hope this is my research team, and I'll be happy to take any questions.
Thank you very much, Dr. Turner, for that very, very stimulating presentation. And of course, bacon is a a southern dish that many people are accustomed to having lots of. The fact that there are 90,000 ages in just a couple of strips of bacon is a very, very thought-provoking
It is, but
fact.
I must say, you do need to live, and we do need to enjoy life, and bacon does taste fantastic. So I still have bacon now and again, but it's not very often, I've got to say, but I'll treat myself now and again. But if you're eating bacon like 2 or 3 times a week and things, then it's going to have a real significant effect from our research. Again, we need more research to really to get to understand this a lot better, and we're starting to get there. But like I said, people got to live. It's just if you know you've had a lot of ages, you can do things to sort of negate that and have a low age meal, do a bit more exercise, have 3 slices of bacon, run around the block 4 times, or whatever it might be.
Okay, thank you very much for that. One last question. I'm going to take the host prerogative and ask you about this, Dr. Turner. It sounds like from your presentation that parents should really think about start being conscious of ages, these advanced glycation end products, um, very early on, maybe even
Mhm.
in the first few months or so of a child's life, setting the stage for a strong body and um, a good foundation for a healthy life later on. What are your thoughts on that?
Yeah, I really believe that from our data that we've got. I won't go into the intricacies, but we've really seen in a lot of our experimental models that during puberty, these ages do a lot of damage, especially when we were looking in, this was mainly in mammary gland development, but we are looking at prostate development now as well. And these ages really disrupt how the breast is formed, and they actually form what we call hyperplastic lesions within the breast, and that's cells that are growing quickly. It's not a cancer, at least it's not a cancer yet. And what we've shown is them lesions seem to persist into later life, and that may be one of the reasons that they get cancer. So while we've got kids on computers and they're not exercising anywhere near, or they're not moving as much as what they used to, I was out in the fields all the time when I was younger. And I think that might have saved me because my age levels are quite low. But it's sort of, I think it's a key to a lot of this. If we can really get our cut down a few meals a week of these high ages, that will really make a difference over the lifetime. And we might, like I said, push these chronic diseases back to being in older age.
Thank you very much for that. I think for many of us, it's a little too late to go back to childhood, but there are some who can benefit. I know. We start
Yeah.
where we are.
Yeah, very quickly. I mean, if we can, ages cause inflammation. If we can reduce that inflammation in the body, our treatments are going to respond better. Our quality of life will get better while we're on them treatments. So there's a lot of things. Just because you're old doesn't mean you shouldn't watch your age levels.
Amen. Thank you so much. We're
Sure.
now going to turn to Dr. Peter Moon. Dr. Moon is the head of the RVA Virginia Prostate Cancer Support Group, a retired chemist, retired biology, retired research scientist at the VCU School of Dentistry, 32 plus year prostate cancer overcomer, and a fountain of information. Dr. Moon, are you prepared to do your presentation now?
Yes, I am.
Okay, the floor is yours.
I'm not sure why my video is not coming up, but I'm trying to turn it on.
Well, you had it on.
I did.
Yes, we can see you there.
Okay, I see you. I don't see me.
Okay.
So I don't know what, I didn't know I was on. Okay. So
Yeah, you're on. Thank you.
so I'm okay. Okay.
Yes, go for it.
Okay. I want to make I'm very much in favor of what Dr. Turner just told you. I took my older brother who had prostate cancer, and he found it a year before I got mine, and he was the one that made me find it early. I found it at 54, which if I'd gone any longer, probably would have been a lot worse than it was. It was bad enough as it was. But I took him to see Dr. Snuffy Myers, a very well-known oncologist in Charlottesville, cost $1,200 a meeting, mainly for him to tell him not to eat bacon. And that was about 15, 20 years ago. My brother lived 34 years with prostate cancer until his mind gave out and he couldn't maintain his treatment. He died this last year, 34 years with prostate cancer. I'm working on 32 years, and I am going to take a different tack that's kind of unusual. I'm going to say that prostate cancer saved my life. And the reason it saved my life was 3 years ago, I was diagnosed with melanoma, very advanced stages. I was November of 2022, and when I was diagnosed, within 3 months, I had 11 metastases on the melanoma. And my ability to treat prostate cancer for 32 years is what kept me alive in treating my melanoma. So I'm going to go through the process of what I learned in prostate cancer and how I used it to treat my melanoma, to help people understand that knowledge is power and it can save your life. And that's what I think it did for me. So in November of that year, I had some responses that were indicating that I was having trouble with my cancer, and I thought it was my prostate cancer. But it turned out that it wasn't my prostate cancer, and they didn't know what it was. So they put me did a CT test on me, and put me in a tube where you go in and out, and they scan you for cancer. And they found something. And they found something so serious that the doctor came down and did a biopsy me right in the CT room on top of the CD table. So he brought his knives and his things. They found a great big mass on my left pelvis that covered the whole pelvis. That was the first metastasis they found. And so they dug in my back, took out some tissue and put it on slides right next to me with just local anesthesia. And from that, they found out it wasn't prostate cancer, it was melanoma. Now, melanoma is considered a hot cancer, and prostate cancer is considered a cold cancer. What that means is melanoma can grow a lot faster than prostate cancer. Prostate cancer, if it's advanced, will grow fast, but if you catch it early, it'll grow slowly and give you a chance to get it treated and maybe cured, like we heard from the other doctors so far. So with that in mind, I proceeded to be diagnosed in November 28th, 2022. That diagnosis was stage 4 melanoma, and by March of 2023, I had 11 metastases. These metastases were 2 in each leg, 1 in the left pelvis that was very large, 3 in the backbone, 1 in the left lung, and 2 in the brain. I was a sad camper. So I proceeded. That was in the middle of January. My right leg was paralyzed from the brain tumor, and I couldn't move it. I couldn't walk. I had to crawl to the bathroom. I had to be taken to the hospital in an ambulance. They did surgery on me within a week after being in the hospital and removed the prostate cancers from my brain. Now, after that point with prostate cancer, I've been looking for it. At this point, I'd had prostate cancer for 29 years, and I was looking for it to get it radiated with SBRT, that's stereotactic body radiation, where it's like a knife. They go in the radiation, they aim it right at the cancer wherever they can find it, and they kill it, hopefully, or at least knock it back and you live longer. Well, I wasn't able to find it anywhere, except I did find a little bit on my right hip when I had an angiom scan in 2018. At that point, I went on Casodex monotherapy. That means I basically block the receptors on the cancer cells, so the testosterone could not get to them. I didn't block the testosterone because blocking the testosterone is very bad for your heart, bad for your brain, and bad for your muscles. It can end up killing you eventually. Usually in 5 to 10 years on androgen deprivation therapy, you'll get to a point, if you have advanced cancer, where you can no longer survive. So with that in mind, I went on what's called monotherapy, and that worked spectacularly for 2.5 years. It lowered my PSA, which was 22 in 2018 when I had my metastasis on my hip from prostate cancer. It took it down to 0.03, 99% drop with just Casodex 3 pills a night. That was a spectacular result. It was so good that I coasted for the next 5 years until just recently with Casodex. And that allowed me to go another 7.5 years without having to do any additional treatment. Recently, I've just stopped Casodex with a hope that my cancer is growing on Casodex and it will stop growing. I've got one more month to go before I get my PSA test, which is so important. Every person should get that if they can get it, to find out where the cancer is. And that's what I've used all along to monitor my cancer and help me with my treatment. So my PSA at this point, it was 4.9 before I stopped the Casodex. After 1 month, it's gone up to 8.9. Now, that is where I would expect it to be, because Casodex has been stopping the cancer from getting into the cancer cells. And that normally knocks it down by 50%. Your cancer is still twice as much as what your Casodex says it is. When you get a PSA reading of 4.9, that really means your cancer is 9.8. And you need to know that so you don't think that you're better than you are, because otherwise you may not think you need additional treatments. So with that in mind, I started to see what I'd done to treat my prostate cancer and try to apply it to my melanoma. And one of the things I'd done was, in my support group, I'd gotten about 20 men to get their vitamin D tested and find out how much they had. Vitamin D supports your bones, and that's one of the important things to prevent your prostate cancer from getting a hold of your bones. You want to have strong bones that aren't osteoporotic. So the average person was taking between 5,000 and 10,000 IUs, that's international units of vitamin D3. Now, vitamin D3 is not a cancer preventer. Vitamin D3 has to go through that you buy over in the drugstore, has to go through the liver and the kidneys to make it into an active form of vitamin D3 that actually fights cancer. So if your kidneys aren't functioning or your liver isn't functioning, you don't get good vitamin D3 to fight your cancer. My other brother has cancer, prostate cancer also, so it's in my family. My mother had breast cancer, so it's a very prevalent thing to know about. But he has a bad kidney. He only has about 30 units in his kidney functioning properly. If it goes much lower, he'll have to go on dialysis. So his vitamin D is not very high, even though it takes vitamin D to try to fight his cancer. So mine, I did a test to find out what what my genetics were in terms of vitamin D3. And it turns out I don't absorb but 60% of the vitamin D I take. So I normally have to take 15,000 international units to get the same amount my wife could get with 10,000. On top of that, I take an active form of vitamin D called calcitriol that actually is an active vitamin D3 vitamin. And that, but I have to be careful I don't overdo that, because I get too much calcium in my blood. It's bad for my heart and bad for my brain and bad for the rest of my body. So I have to be careful I don't overdo it. So I usually take it about every other day, the calcitriol. So with that in mind, I wrote a paper on that and sent it to a cancer journal on what I'd done with my support group and with my 20 men, and how much vitamin D they were taking and how high the vitamin D was in their body. Well, they turned me down in terms of accepting the paper, but they liked the paper so much, the authors of the journal did, they asked me to be a reviewer for them. So in the process of that, I reviewed a paper showing that vitamin C infusions fought cancer of the lungs very effectively. It increased the survival by a factor of 3 for advanced people with lung cancer. People that took vitamin C live for, instead of living for 3 months without it, they live for 9 months taking vitamin C as an infusion. So that was added to my treatments for my melanoma. The other thing I did was I went to my doctor. Before there, I went to a doctor, Pokovich at VCU, and he explained to me there was a new treatment out there, a chemotherapy for melanoma, and he looked at all my slides and all my metastasis and pointed out what was going on there. And he told me about this new treatment called Opdualag. Well, Opdualag turns to be better in terms of having less side effects than the normal nivolumab and immunoplab. So I got my doctor to start giving me that Opdualag. They had never done it before. They'd never used it. He went to his pharmacist and asked him if he could start doing that. It had only been on the FDA approved for 6 months. And he came back in 15 minutes and said we could start doing it. And we started doing it in January, right about the time I started to get a leg. My leg became paralyzed. So that was started right before that. But when my leg was paralyzed, I was taken to the hospital in an ambulance, and they operated on my brain within a week, and they removed the brain tumors. So I stayed in the hospital for another week or so, and then I was taken home, and the rules said I had to stay home for 2 weeks before I could go back to the hospital. So I stayed home with the nursing care in the bed for 2 weeks. Then I went back to the hospital for rehabilitation to learn how to walk again. And I stayed in the hospital for about 3 weeks to learn how to walk. But in the meantime, I had to sneak all my treatments for prostate cancer into the hospital and take it myself, because they wouldn't let me have them in the hospital. They wanted only to use what they gave me. So I snuck them in there and didn't tell the doctors. What the doctors doesn't know won't hurt them, but it will hurt me. So every night I would take the pills when they were out of the room. So I learned to walk again, to the point now that after 3 years, I can walk 1.5 miles a day using walking sticks or hiking sticks in my area, up and down a real big hill. If the weather's warm enough and cold enough, I do that. If it gets too cold, I have an indoor walking platform that I get on and walk. I have all kinds of machines. When I cook something downstairs, I have to lift weights while the stuff is cooking. I have to get on my treadmills and my walker bicycles, and I have to pump them. So I get exercise, like you heard from Dr. Turner. You can't live if you don't do the right thing. If you don't eat the right thing, and if you don't do the right exercises, you will not live very long. I've lived 32 years, and I plan to live another 8, at least 5. Everybody in my family has died at 89 recently. My mother died at 89 with Alzheimer's. My sister died at 89 with Alzheimer's. My brother died at 89 with prostate cancer and Alzheimer's. So I've got 4 more years before that. But so far, I haven't had any signs of Alzheimer's. Occasionally, I'm missing words, but I tend to get around it. But they were all having mini strokes in the early 80s. I haven't had any yet. So they gradually got worse in their 80s, and to the point that it was hard for them to keep in their mind that I talked to them on the telephone more than another couple hours afterwards. So anyway, my brother died more from Alzheimer's than he did from prostate cancer, because he could no longer get the treatment for prostate cancer because he couldn't take the pills that he needed for his medicine. So now you've learned that one of the things that I started doing was getting IV vitamin C. The other thing I did for my prostate cancer, I got 8 of my 11 metastases treated with SBRT radiation, either 1 or 2 shots of radiation to each of those 8 of those spots. The other ones were in my legs. I didn't get treated. So that my Dr. Cutno, who I knew, her father-in-law was at the dental school where I worked for 48 years, teaching and doing research on materials and tissue, bone tissue and engineering. And all that helped me. Because the other thing it did for me was when I first got biochemical recurrence in 2000. I had surgery in 1994. The surgery got rid of the cancer until 2000. In 2000, you have reoccurrence if your PSA goes up to 0.2. Mine was at 2.9 when I started a treatment called Avodart. I think I've talked you into doing that, Jonathan, if I'm not correct. You're taking Avodart, aren't you?
I am, and I'm taking it twice a day.
Yeah, okay, that's good. I'm taking Avodart and Prosgar. Prosgar was the first one that came out. Avodart is better because it blocks 2 alpha reductase that fight the cancer. What happens is alpha reductase makes dihydrotestosterone. Dihydrotestosterone is twice as bad as testosterone in growing prostate cancer. So I block the worst thing. It's 10 times worse than testosterone. I keep the testosterone and I block the dihydrotestosterone. So the other thing I've added to it is from my information at the dental school. I know that when people have their teeth fall out due to periodontal disease, the collagen from the ligament to the tooth breaks down due to matrix metal proteases. They tear the collagen into little pieces of amino acids, and then the ligament holding the tooth in falls apart, and no longer your tooth falls out, and you lose all your teeth if you got periodontal disease. Well, the same thing happens around if you have prostate cancer or any other cancer. If you have a problem where the metal proteases break down the matrix around the metastasis, it'll go into the blood vessels and go to the rest of the other places in your body and land there and grow more metastasis and end up killing you. It's the metastasis that kill you by destroying other parts of your body, so you can't survive. So what I did was start taking doxycycline, which is an antibiotic that kills MMPs. That's what the dentist does to fight periodontal disease. He sticks a little chip for $200 down into the sulcus around the tooth, and that kills the MMPs and keeps your periodontal bone fibers from breaking down or holding your tooth in place. So I take 100 milligrams of doxycycline a day for the last 25 years. and that kills all the MMPs that want to make my cancer spread. My cancer has not spread anymore, so I can no longer find it. So when I look for it to radiate it, I can't find it. So with that in mind, I'm now using my treatments for prostate cancer. But through that, I've added one other thing. I've added a treatment for find the right word now. Treatment for fighting what's the word? The treatment involves fighting the cancer by fighting the spread of the cancer through immunotherapy. I'm taking an immunotherapy for a year and a half until I got psoriasis reaction side effect, and then I had to stop it. But in the meantime, all my cancer has disappeared. All my 11 metastases are gone. I get them checked every 3 months now. So the only other thing that I know that's helped me fight that is the COVID-19 vaccines have just been shown to fight, to improve your immune system. And so that added to my immune system fighting my melanoma. So those are the things that I learned from having prostate cancer that have killed my melanoma. And that's why I'm still alive. That's why I'm still talking to you. I'm not bringing up Daisy somewhere in next to my wife, who I lost 3 years ago, and I miss her every day. So with that in mind, I want to stop so that your wife has a few minutes to say something. So everybody learn and find out what you can about prostate cancer. What I do is I take a Google thing and I put whatever I want to find out about and put it with prostate cancer, and I find out that it fights what fights my prostate cancer. And I just found out today that when I Google doxycycline and prostate cancer in 2017, a paper was produced that shows that doxycycline fights prostate cancer. So I did it before it was ever published. So sometimes a blind squirrel finds a nut every once in a while. Thank you very much. God bless you all. Amen.
Thank you very much, Peter. You have been a blessing to us in the support group, and certainly your presentation this evening has been very moving. It shows how knowledge and wisdom united together, along with the determination to live, can produce very good results. And even sometimes the things that look so difficult and so bad, like prostate cancer, may have a silver lining there. And as you said, it helped you to first discover that you had melanoma, and in defeating the melanoma, you've also been able to rearrest prostate cancer. And I want to agree with you that your best days are still ahead, and that you will shatter the family record. You will blow past 89 and 99 as well.
Well, I've got a target anyway.
So thank you so much. And we're getting towards the end of our time now. I want to say a few words about faith. I also want to put on the screen some information for you all that you can perhaps take a screenshot of, and that is with regard to the contact information for our extraordinary speakers this evening. The program is being recorded, and we hope to have it uploaded so that folks can see it, and we'll certainly share it with all of the participants. On faith, I was diagnosed with prostate cancer 20 years ago. And I remember going into the doctor's office and being told when it was my turn to speak to the doctor, his first words out of his mouth were these: "Mr. Stubbs, you do have cancer." Now, that was not as unsettling to me as it might otherwise have been, because I do believe in God, and I had been praying about how to handle whatever situation came up. And I had sensed that I probably did have prostate cancer. So I wasn't as unsettled about that as I might otherwise have been. I went to several doctors. My wife went with me every time. And I was told you should have surgery or you should have radiation. And given my background, I I'm I questioned things, and I said, "Well, suppose I don't do that, then what's going to happen?" And I said that to the head of the urology department at UVA at the time, and he told me, "Well, if you don't, in 5 to 7 years, you're going to be in some serious trouble." And so I took that to heart, um, and in my prayer life, I said, "God, if you want me to have surgery or radiation, fine, but I would like to to overcome this disease without surgery or radiation. And I'll need you to show me what I need to do in order to do so." Because I felt there was no sense in my asking God for something and I wasn't willing to do something myself. And one Saturday morning, I felt impressed to pick up a legal pad and start writing. And the first thing that came to mind was exercise. Exercise physically, don't be a couch potato, but also exercise your faith. Part of the battle to survive, to overcome disease, is in between the ears. So often, discouraging thoughts will come. This is stupid. You heard what the doctor said. You heard what everybody's saying to you. Nobody's doing what you're planning to do. Don't do it. Don't be a fool. And yet, at the same time, because of my um, prior experience in church services and seeing how God could move and had moved in the lives of my friends who had been miraculously healed, I knew that it could happen. Couldn't make God do it. Can't twist God's arm and force God to do anything, but I can certainly ask. Exercise, first thing. Exercise your body and exercise your faith. Second thing, change your diet. Eat dark green leafy vegetables. I wrote that down. Eat cauliflower and kale. Eat broccoli. Eat eat greens, onions. Eat nuts and fruits. Drink lots of water. Drink tea, and have some fish. Now, for those who don't know, I'm a country boy. Grew up in the South, rural area, and all of those things that Dr. Turner talked about eating, and they're fried and broiled and charcoaled and every other kind of concoction you can think of. I had it and enjoyed it. And none of that was on my diet. I was like, you know, and of course, to make matters worse, I'm a Baptist preacher. I mean, if I go to a homecoming service or something, what about the fried chicken? What about all the stuff that they're going to have? Well, none of that was on my diet. Okay, got to make some changes. In addition, and there was rest and meditation. I was impressed to do that. I wrote that down. Get the junk out of your life. The reason that this picture is blurred is because I haven't succeeded in doing that yet. And I don't want you to see the junk that still surrounds me. But it's an issue. Not only clutter, but also junky relationships, stress, unnecessary conflicts, and confusion. All of that is draining, and it can lead to bad results. And last of all, share the testimony, share the story. So that's part of the reason that I'm here tonight, to simply encourage those folks who are on the line, who are listening in and who are watching, that you need to hold on to your faith. If you have faith, hold on to that, exercise it, and do your part. Uh, the Almighty always does God's part, and so I read in Isaiah chapter 41 around verse 13. God says, "I will guide you with my right hand. I will help you. Not I might help you, not as possible, but I will do it." And so I rely on that. Now, at the same time, and I'll close with this, it is very necessary to, and then Peter was mentioning this as well, to not become complacent. I've been on this prostate cancer journey 20 years now. I do take chemotherapeutic drugs. I take Casodex like Peter, Avodart, Celebrex, doxycycline, letrozole. I, I also take various supplements like curcumin and resveratrol. The vitamin D3, I take about 10,000 units per day. Those are some of the things. But recently, I noticed that I've been a little complacent, and my PSA has started to climb again, and that's gotten my attention. My PSA usually over the last 8 or 9 years, it's been in the 20s. I still have my prostate. It's been in the 20s, sometimes low 30. Most recently, it's gone up about 7 or 8 points. It's around 38 now. So that means I've got to do something, and I will do something. But I also declare to you that the fact that I'm here 20 years after diagnosis and after folks had told me with a 4+3 Gleason cancer, that in 5 to 7 years, if I didn't follow the so-called gold standards, I would be in serious trouble. Well, I may be in trouble, but at 70 plus, I am grateful that I've had a good quality of life, and I expect that I'm going to break the record in my family, which is 102 years. And so that's my goal. But I know it's more than talk. You got to actually back it up and do something as well. So with that, I'm gonna I'm 3 months. I'm three minutes over the time. I do want to briefly share um, the contact information for our speakers. You have it in the chat, but it came out a little jumbled, and I'm sorry for that. I'm gonna see if I can do a little bit better here. If I can, yes, here it is. And this is the information for Dr. Coleman, Pamela.Coleman at howard.edu. Her contact information if you want to reach out to her directly. Dr. Turner, David.Turner1 at vcuhealth.org. So you can reach out to him there. For Dr. Moon, pcmoon at vcu.edu. And there's also the webpage for the prostate cancer support group here in Richmond, Virginia. And there's my email address, jstubbsfshg@yahoo.com. So that gives you some of the information about being able to follow up with some questions. We are over time, but for those who are able to stay, some of us may stay a bit longer and have an opportunity for some further interaction and some further questions. I also want to draw to your attention that in the email this evening, there was sent to you a workbook which has some questions about our presentation, questions about prostate cancer, about advanced glycation end products, um, about um, about the role of support groups in helping us. That workbook is to help reinforce the information that we've gone over today. And also, if there's sufficient interest among members of this group, we may have a follow-up session of interested persons in the near future, and we can go into more detail about some of the questions. But while we are here now, I'm going to ask if persons who would like to ask questions and you're able to raise your hand in the chat virtually, we'll recognize you first, and then after that, those we'll ask people to unmute their mics. Before I do that, though, I do also want to recognize Dr. Pamela Hamilton Stubbs, who hasn't spoken this evening, but she's the one who is really the principal organizer and the energy behind this program. And I would like to give her an opportunity, if she would choose to say a few words about anything that you would like to say, Dr. Pamela Hamilton Stubbs.
I think this was a hope I got rid of the echo. I think the program was well done, very informative. I want to thank all of our speakers and you too, Reverend Dr. Stubbs, for the time and the commitment to put this together to try to help other people and to help ourselves. This is information that we can use even if we don't have a problem of prostate cancer. It is a way for us to be healthier because ages have been linked to so many things that are now labeled chronic diseases of aging. So any information we can have on how to enjoy the golden years, I find it helpful so that we can maintain our health and serve the Lord with some energy and purpose. I would like to let people know that I'm trying to send out a follow-up questionnaire. If you did not sign up on the website or at a where you got emails, if you were just given the link and you want the form, please put your email in the chat. I will send the form out to you to get some feedback. We use the feedback to try to improve our programs. We'd like to know, what do you want to learn more about? And did you find it useful? And how will you be using this? Will it make a difference in your life? So I want to thank you for coming out. I thank everyone for your time. It's a blessing to serve. I hope you've been blessed. And don't forget, go out and bless somebody else. Thank you.
Amen. Are there questions in the time that's remaining? We've kind of extended the time, given the level of interest. If you have questions, now is an opportunity to ask those questions. We'll look for hands first, and then we'll just ask people to unmute. Any hands of people who would like to ask a question of our speakers? Ms. Atkins, I recognize your hand.
Oh, good evening, and thank you very much for all the information. My question